Welcome to my presentation on some ideas for behavioral health and recovery services to improve services and consideration of a new way to organize our system of care. I've made this presentation to over 15 groups of stakeholders from around the county, talked to over 1,000 people, and we have received some really valuable input on the ideas that I have in this PowerPoint. We will continue to look at the feasibility of this and continue our dialogue with our stakeholder community. This past year in 2011, the Affordable Care Act was passed by Congress, signed by the President. The Affordable Care Act, otherwise known as health care reform, recognizes the importance of behavioral health issues in the overall effort to improve health care in this country. We were fortunate to have some very strong federal advocates that put forth the connection between behavioral health conditions, overall health conditions, and how it can help control costs and improve quality. Therefore, behavioral health services is well integrated into much of the Affordable Care Act. After the passage of the Act, SAMHSA, the Substance Abuse Mental Health Services Administration, released a paper, Description of a Good and Modern Addictions and Mental Health System, that foreshadowed what this good and modern system may need to be in order to fully participate and respond to the requirements of Affordable Care Act and to the needs of our communities and individuals. In addition to the significant impact that healthcare reform may have on our delivery system, there are other important changes that have been occurring at the state level that also raises the opportunity for us to assess where we're at as a system of care and to really think about, are we positioned to best provide the highest quality of care for people seeking our services and for the communities we work with. Those changes at the state level are reflected in the governor's proposal on realignment of mental health and substance use services. On the mental health side, it's really the culmination of what started in 1991 realignment, and it's a new proposition for substance use treatment to be realigned to counties. In a nutshell, what that means is funding for those services will flow directly to the county after receipt by the state of vehicle license fees and sales tax revenue, and that the counties will have full responsibility for services, which otherwise known as risk, to manage the overall population. It's a good opportunity for us, and it also has some risk that we need to make sure we're positioned properly to manage. The other major change at the state level is parole realignment, which shifts responsibility for a subset of offenders who had previously been incarcerated in state prison and supervised by parole will now be the responsibility of the local jurisdictions for supervision and treatment and incarceration. And we've been working with our criminal justice partners to provide a plan and a response that can best meet the needs of that population, which we all know has high rates of substance use and mental health conditions. What I want to focus principally on is the Affordable Care Act and how it reflects a potential roadmap for our consideration. So the SAMHSA folks visioned that this paper would help to identify some key elements in this modern system of care that I'm going to go through. The good and modern system would not only focus on effective treatment and recovery services, but it's a clear recognition, one that we spend a lot of our time on and clearly recognize it here locally, is that for people to be in recovery and to lead a quality life in the community, they need to have access to health care and connection. They need to have ways of being as self-sufficient as possible, whether it's through employment or public benefits. They need to have housing that's safe and secure, and they need to promote their own education if that's relevant to them. The other part of the good and modern system, somewhat related to the first bullet, is that there is this strong emphasis in the healthcare reform legislation in many instances of how primary care and behavioral health care needs to be far greater integrated than it's been historically, and that a holistic approach to one's care should be delivered as much as possible. The good and modern system would have these following elements in it. It would have a very high degree of accountability, basically delivering what it says it will deliver. The system needs to be organized as much as possible. And in healthcare reform, there is something called the 3 aims, which relate to improving individual health outcomes, improving the overall health population, and controlling cost. So this third bullet of the good and modern does control costs while concurrently improving quality. That may seem like counterintuitive. How do you control costs and improve quality? I would flip the order of this bullet and say by improving quality you actually control costs, because you should be able to prevent higher levels of care, emergency rooms, psychiatric hospitalizations, which are the highest cost in healthcare. The system also needs to be accessible. People should be able to get into the system in an easy way. They should be able to get to where they need to be to get the services that are required for them. The system needs to be equitable, meaning that the level of services and the types of services should be distributed across an area that makes it distributed in a way that anybody can get what they need in the area that they live. And the second to last bullet is the system needs to, again, be effective, meaning it has to have a high quality. Overall, the good and modern mental health and addictions system needs to be seen by the public as really a public health asset that in its totality helps improve lives and lengthens one's lifespan. And we know how relevant that last portion is to our population given recent information about length of life. The good and modern system results in a number of things, that not only are we treating people once they are symptomatic or become ill, but there needs to be a very strong and high emphasis on helping people avoid illnesses, whether it's behavioral health illnesses or general health illnesses. And then once we work with people, it's not just about helping them get well, but what kinds of services and supports are available to help them stay well. So those are 2 really key results that the system needs to continuously pursue. The system also is one that emphasizes a number of really key things. The system is about recovery and resiliency, which really speaks to the long-term trajectory of how somebody becomes well and stays well. And that the system is not just about treatment, but to do things in primary prevention and early intervention. I spoke about on the previous slide the reasons and the needs for cost effectiveness, and that the system needs to really focus on historically unserved and underserved populations. We're fortunate through the Mental Health Services Act that there's been such attention to increasing access and providing culturally relevant services to underserved populations. Additionally, the system, as I mentioned earlier, not only is integrated, but that the access to the system provides the right therapeutic dose. The system shouldn't overprescribe or underprescribe. We should be able to assess the needs of an individual and, to the best we can, provide the right level of intervention and support. The system also discussed the need to be organized, and that's reflective in having standards of care that are consistently applied throughout the system, and that we utilize a number of tools to help us make sure that the quality that we deliver is always being assessed and that we have a continuous quality approach. And that's through the data that's collected. We historically, like most governmental entities, collect lots of data, but unfortunately lots of that data doesn't get transmitted into information that we use to really assess how we're doing and to find ways of improving our care. That needs to be a focus. And the last bullet speaks to the importance of the workforce. Imagine that there are 46 million people in this country without health insurance, and that through the healthcare reform legislation, 30 million are now insured, and let's hypothetically say 15 million of them now feel like they want to enroll in primary care. There certainly is not the number of primary care physicians or nurse practitioners to be able to meet that level of demand. Nor in the behavioral health world is there enough clinicians and counselors and peer support and family partners to meet the need of the pent-up demand that we may see as a result of healthcare reform. So the workforce development piece that we've done through MHSA to a limited extent really will be required to be a primary focus if we're able to meet all of the other requirements of a good and modern system. So in the review of this paper, and by the way, the full paper is available on our website for you to read if you so choose. But our question, once we read through the paper, is to look at our current system and ask, is ours a good and modern system of care? And if there are some areas that we're lacking on, how do we move towards this good and modern system of care? So I want to provide a little history that is relevant to our development as an organization as Behavioral Health and Recovery Services. Before 2007, Alcohol and Drug Services was part of the Human Services Agency, and Mental Health was part of the Health Department. Additionally, that's not shown on this slide, the San Mateo County Hospital and Medical Clinics was its own department, so there could be a third box here. And there was work done prior to 2007 in our co-occurring initiative between Alcohol and Drug Services and Mental Health that really started to move us along a continuum to work more collaboratively together. In 2007, Behavioral Health and Recovery Services was born. The Board of Supervisors accepted a recommendation that was developed through a long series of conversations with stakeholders and staff from both services. And the health system was actually reconfigured. That included the San Mateo County Medical System. And so they're now a division within the health system overall. So this afforded us an opportunity to accelerate the work that we were doing around providing better services to individuals with co-occurring disorders. This slide shows our organizational chart, and there's the red box that highlights the alcohol and drug services portion. Before the integration, if you can imagine, you would extract the red rectangle, and that would be the mental health department organization chart at the time. When the integration occurred, we basically made some room in that larger organization chart and stuck AOD services in there. And we really didn't attend to any specific organizational changes that would be more reflective of a movement towards co-occurring integration. There were some responsibilities that individuals took on that were more around integration. For example, our medical director at the time, Celia Moreno, assumes medical responsibilities for alcohol and drug services, where alcohol and drug services prior to the integration did not have any medical directorship. And I was in the position of Director of Alcohol and Drug Services at that time and took on some Mental Health Services Act prevention and early intervention responsibilities. But we really didn't do any other structural changes. Also, during that transition time, we created a group of stakeholders called the Transition Management Advisory Group, consisting of family members, consumers, providers, and staff, to consider what were the important milestones that this organization, Behavioral Health and Recovery Services, should achieve over the next year. And that group did identify milestones, which were very helpful. And they also helped draft a new vision, mission, and values statements that would serve as important guides for the organization. Additional work that was done at the beginning in 2007 was to create these building blocks, basically important areas that we wanted to maintain a focus on in order to continue to strengthen this new organization. And you'll recognize the boxes as you read our newsletter, Wellness Matters. Articles have a box attached to them to help connect them back to this ongoing effort in one or more of these areas. So in 2007, when we were coming together as an organization, we held an off-site retreat of management staff from both mental health and alcohol and drug services to consider the new organization, what were some of the things that the transitional advisory group was recommending, and how we could make the transition as smooth as possible. We discussed a number of ideas at that time. One of the ideas that was presented was consideration of organizing our services, both county operated and contract, on a regional basis. And we had some conversation at that time, but never did anything about that as we focused on other things. Last October, about 5 months after I became director, we had another offsite, the first one in that 4-year period, to look at the organization and also to look at the paper Good and Modern system that I was mentioning earlier, to ask and answer that question, is ours a good and modern system? As the first retreat, we discussed lots of ideas, and this notion of providing a more organized regional level system of care came up again. So rather than just have it lay dormant, we decided to explore what that might look like in a little bit more detail. And that's what I want to present at this time. The information on this slide is a concept, and like any new concept, there really isn't a level of detail behind this that would get into the specific how this would happen, and the specific operations and the specific of where these would be, etc., etc. It's a concept that we've asked people to respond to. I'm going to go through the concepts of what we're calling community service areas and the wellness diamond. Remember in the earlier slides on the good and modern system, it talked about being recovery and resiliency oriented, and that's certainly what we would propose in this concept, that the community service area and the wellness diamond would be really recovery and resiliency focused, that's clearly connected and grounded into the specific communities in which the services are provided and with the individuals and family members that receive our services. In the community service area and the wellness diamond, we would essentially serve all of the populations that we currently serve. And as you'll see in this slide, we attach families to all the populations and describe families not necessarily as bloodlines, but essentially as anybody who the person who's seeking and receiving services feels is an important person or persons for them as part of their support system. That's who we're calling families. And those populations would be our targeted population within the wellness diamond. Now, over on the right-hand side, I want to focus on a number of parts of this diamond. The first is the outer part where it says community, and you will notice on the outer lines of the diamond they're broken and there's a reciprocal arrow between the diamond and the communities. And this is to convey two things. One is, we know when we look around San Mateo County that there are very distinct and very different populations and communities, and their culture, their norms, their values, the demographics are very unique. And what this is to depict is that services are going to be delivered in a specific community that would connect to the values, norms, and demographics of that community. And services could be and should be tailored to the maximum extent possible so that it's a welcoming environment and the system of care is very accessible to the people that reside in that community. And recall, one of the important parts of the good and modern system is that they're seen by the community as a public health asset. And the concept here is that the stronger it's connected to the particulars of that community, the community itself will see the services as a public health asset. The second part of the community relationship is obviously individuals and family members make up the community. And we would want that there's easy entrance into the services and supports that BHRS has to offer for individuals and family members living into the community, and that they can get to the place inside the diamond to where they need to go. And there isn't a linear path for them to go from service A to B to C, and maybe if they fail C, they can get to D, but that they can get to where they need to go. So if an individual in the community may feel they need short-term early intervention, they could go right to early intervention services. And maybe it's an 8 to 10 week group that's very skills focused. And in the course of that group, they feel like they really would like to find a way to get engaged in longer term recovery supports, and they would have an easy way to do that. Focusing on the inner diamond, you'll see for just simplicity's sake, we divided the diamond into 4 parts with an overall description of the services that would make up that particular area. And we also broke the diamond in the middle to again reflect that there would be easy movement between those areas of services for people so they can get to what they need, when they need it, and where they need it, and that there would be a flow. And this reinforces many of the things that the Good and Modern paper described in terms of getting services to people in a way that they need it and when they need it, kind of that right therapeutic dose. The second part is what would be the structure of this community service area and the wellness diamond. Imagine that this community service area is a mini behavioral health and recovery services, meaning that it would offer for a particular community all of the range of services. For the most part, there will be exceptions, a core set of services that were specific for that community, but it would basically be serving all the populations that we serve, and prevention, treatment, and recovery, as well as mental health and substance use issues. So they're all mini behavioral health organizations. We don't know how many there might be. That would be work that we would need to do later to determine how we would actually develop criteria to determine a community and a community service area, but that would be work subsequent to this phase of our exploration. Suffice it to say that each one of these community service areas would have a behavioral health and recovery services manager, and they would be the single point of accountability for that CSA. They would have responsibilities for all of the directly operated county services that may reside there, as well as oversight for the contracted providers from that community, including contract monitoring. A very important function of the manager would, as well as other staff, but principally the manager, would be to develop the community relationships necessary for this community service area that he or she is responsible for to really have solid and broad relationships with the community. They would need to really spend time cultivating those relationships, whether it be the faith community, the business community, law enforcement, or other key service groups, etc. We're also envisioning a community planning committee. This would be not a policy group, because our policy group is the Board of Supervisors, but basically providing advice, input, and guidance in the delivery of services for that community service area, working closely with the manager. We don't know how big they would be. They may vary depending on the community, but nonetheless, each community planning committee would be comprised of 51% or a simple majority of consumer and family members. In addition, we would have representation from contracted agencies, other private agencies, key public agency partners, and representatives from advocacy groups. And what they would do is work closely with the managers and staff around understanding the particular needs of the community, developing services and supports that are responsive to the nuances of that community, and also helping to evaluate how well the services are functioning and what outcomes are being delivered in that community, and then being involved in a continuous quality improvement process. Each one of the community service areas would have operating under some guiding principles. I've talked a lot about the community and the importance of being connected to the community in order to improve one's health and also the overall health of the community. I've spoken about the integration with primary care. But additional key principles that the community service areas may help facilitate would be the further integration of mental health and substance use services, and when possible, when feasible, actually provide more co-location opportunities. Now, we're not proposing at this point that every service be fully integrated. That's not realistic, but we do believe this will create an opportunity that may create more opportunities to make this happen. But it would be a guiding principle that we would look for. Same-day access would be a guiding principle, again going back to how do we make a system of care one that's easily accessible and removing unnecessary administrative barriers. So that would be a principle. Increasing the opportunities for peer and family supports to help support clients as they work through our system of care. I've also spoke to the right therapeutic dose and levels of care matching clients' needs. And the last bullet I would like to highlight, and that is looking at opportunities that our hours of service and our entry points would be much more flexible. Can we provide more evening hours? Can we provide some weekend services and supports? But those would be, again, guiding principles that the community service area and its partners in the community and the community planning committee would continuously be looking at as a community service area was developing. In each one of the community service areas, we would define what would be a core set of services that would be common to each CSA. But we would also look at what additional services are important for that particular community that may not be needed in all the other CSAs, or maybe not needed in any of the other CSAs, but specific to that particular community. So it would be a combination of a core set of services, uniformly applied through all the CSAs, but flexibility to consider and offer additional services specific to the community. I've mentioned that this is about all levels of care. So in the core set of services, it would be provision of both substance use and mental health services, and through the continuum of prevention through treatment and recovery. The community service areas would work on a strong connection to those other key elements of the continuum that was in the very first slide on the good and modern system. We know people can need to have proper, safe, and supporting housing in order to recover. There needs to be a level of self-sufficiency, etc. The community service areas would also be an opportunity to further much of the great work that's been done in this county around connecting primary care and behavioral health care. And it would also provide more opportunities for peer-run support services as an adjunct and a support to the clinical services that we currently provide. This motivation for the community service areas was first stimulated by our review of the Good and Modern paper, and again trying to answer the question about, is ours a good and modern system? But it also is an attempt to address some other problems that we have in need of improvement, and they're highlighted on this slide. And they are, how do we create greater equity in the ability for people to access what we do? We know there's variance in how we apply standards of care, how policies and programs are implemented, monitored, supervised. I believe that although there's examples of good connections to some communities and improving relationships with communities in the county, I believe that there's still great opportunity to more fully optimize our relationships with the communities in the interest of supporting our clients and our family members, and to work on issues of stigma, etc. We've made some significant progress in our co-occurring initiative around substance use, mental health, and trauma, but we have a ways to go with that. It's still an issue, a challenge for us. We've also done a fairly good job of using and working with consumer and family members, but we have a ways to go with that, as well as we see the value of consumer and family involvement in our care. And lastly, when there isn't a more locally attached accountability, and the accountability is only at a broad county level, it really starts to break down the relationship between the community and the overall delivery of services and accountability. And we think that's a problem, and that we need some work done on increasing accountability and the transparency of what we do. So given that list of challenges, we think that the CSA may provide us an opportunity to address those and make some progress. And these are some of the ways we think we could do that. The core set of services would help with equitability across the county, and it may improve access. That the application of standards of care in the policy and program administration under that single manager for the CSA could help further greater integration. It will lower the level of accountability and transparency to the specific community in which these services are delivered, and the specific community would be engaged in assessing the delivery of services. It certainly, in my mind, would promote much stronger community involvement that could really tap unused resources currently in the benefit of our consumers and family members. So that's the crux of the presentation, and what we've been asking people is for their input. I want to stress a couple things. One is that there's been no decisions made as to whether or not we'll actually implement this. We've been very cautious and deliberate in making sure we're having presentations and conversation with our relevant stakeholders. We understand how dramatic a change this could be, and so we want to do it right and not fast. And we only want to do it if it helps answer more challenges than it creates, and that at the end of the day it provides a higher quality of care. The other thing I want to say is that the consideration of this proposal is in no way a statement that what we do currently is not of quality. In fact, I would argue that we wouldn't be in a position to consider this proposal if in fact the current delivery of services was not of a quality nature. That it's only because of that strong foundation that we can actually think about these things. And finally, this is also meant to stimulate conversation with our stakeholders, both externally and internally, around how we can continuously be an organization that's focused on continuous quality improvement. We do good work with many people, but we can always do better, and this is the opportunity to stimulate that. So I really want to thank you for logging on and hearing the presentation. We will take the input that we've received and consider our next steps. If we decide to go forward, our next steps will be to flesh out more of the details of this redesign, and then seek additional reaction to it before any other decisions are made. As I mentioned, there's no timetable. This process is all internally initiated. There's no external pressure or mandate from anybody that we need to do this. So we can put a stop to it at any time, but at this point we'll continue the path of exploration. So thank you again, and I appreciate your interest.